Okay, great pleasure to introduce Dr. Pierce Keane. Pierce is an ophthalmologist at Moorfields and at UCL as well. And Pierce has an interest in AI. He developed a collaboration with DeepMind and has been using AI in ophthalmology, and he's going to tell us about the potential of using AI in healthcare. So Pierce, thank you.
First of all, Sir Munir, thank you for the invitation to speak. And let me just say, I'm sure probably a lot of other speakers have said this already today, but what a joy to be back in an in-person lecture. So I'm really, really looking forward to telling you about some of the work that we're doing. So as Munir has said, I'm going to speak about the potential of artificial intelligence to transform healthcare. And of course, I'm biased, but I do believe that ophthalmology is at the forefront of that transformation and can be an exemplar for other medical specialties in that regard. The other thing that I'll say is that I've included my Twitter handle in the bottom right there, if anyone would like to get in touch with me. I'm always looking for more followers on Twitter. I'll also give my email address at the last slide as well, so if anybody prefers a more conventional route. So my background, as Munir has said, is that I'm a consultant ophthalmologist at Moorfields Eye Hospital in London, and my clinical area of expertise is in retinal disease. So in particular, I specialize in things like age-related macular degeneration, or AMD, which is the commonest cause of blindness by far in the UK, and in Europe and the US and many other countries and regions around the world, and other diseases such as diabetic eye disease, which of course is one of the commonest causes of blindness in working age populations. And then the other thing is that although I'm not a computer scientist, I'm not an engineer, and really have somewhat limited technical skills, I've somehow come to find myself leading an artificial intelligence group at UCL, a sort of diverse, multidisciplinary clinical research group that aims to develop and apply AI in healthcare. Again, using ophthalmology as an exemplar, but not limited to ophthalmology. And then just one other plug is to say that I'm very fortunate to be funded by UK Research and Innovation as one of their Future Leaders Fellows. And for me, that's very exciting to highlight just because it funds research that is at the boundary between different disciplines and at the boundary between academia and industry. And then in terms of my disclosures, given that I might get overly enthusiastic over the next 10 or 15 minutes, it's important to recognize that I have acted as a consultant for the artificial intelligence company DeepMind. And then at the very end of my talk, I'm going to tell you a little bit about a project that I've just started with a UK startup called BitFound, and I act as an advisor for them. So what I'm going to cover in the next 25 minutes is telling you a little bit about the Moorfields DeepMind collaboration, how it came about, where it stands, what the next steps are. Then I'm going to try and be a little bit speculative and talk a little bit about what I think is an emerging ecosystem for AI-enabled healthcare. And the spoiler is that I believe that clinicians, that healthcare professionals, are going to be key to the next phase that we're quickly entering of AI-enabled healthcare. And then very briefly at the end, I'm going to sort of speculate about what I think is the future for clinical data sharing in 2020, in the rest of the decade, and what it might look like by 2030. So why do we need new technologies and innovation, and in particular the hype of AI in ophthalmology and in healthcare more general? Well, this is a slide that I love to show, particularly to non-ophthalmology audiences, because I think among some other medical specialties, there may perhaps be a perception that ophthalmology is kind of like a small specialty or a niche specialty or somehow kind of a cushy number in some way. But in fact, since 2017, ophthalmology has overtaken orthopedics as the #1 busiest specialty in all of the NHS in terms of clinic appointments. Nearly 10% of all clinic appointments in the NHS are for eyes. That constitutes nearly 10 million appointments per year, and that has grown by about 37% in the last 5 years. So if it's not too brutal a way to phrase it, we are drowning in the number of patients that we need to see. Now, as a result of that, unfortunately, the reality is that there are patients that are going blind because of delays being seen and treated. And this is not just an issue in Moorfields, not just an issue in the NHS, but an issue around the world. And so what I believe is that AI can, at least in part, begin to address some of those challenges. Now, when I talk about AI, really I'm talking about a technology called deep learning. So AI is a term that's been around for 50, 60 years, or perhaps longer. But it's in recent years that a subset of AI called machine learning and a subset of machine learning called deep learning has reignited a lot of the hype around AI. And in 2015, Scientific American listed deep learning as one of their world-changing ideas of the year. Now, deep learning is essentially really just another way to describe something called artificial neural networks. And artificial neural networks are computational models that superficially, and I'll underline superficially, resemble the brain in the way that they process information. And essentially what you do is you get some bit of data. You might get a photograph, for example. You convert that into a grid of numbers, and then you convert that into a vector, and then you feed it into a neural network. And then what will happen is each of the layers of the neural network will begin to extract increasingly more abstract representations of that data. And ultimately, it can do some task at the end, like a classification task. Now, a lot of the time you look and you see pictures like this describing the neural networks, and you see these circles, which are called nodes or neurons, and you see these lines, which are the weights or the parameters or the connections. And it kind of looks very simple. But actually, I used to puzzle over these things when I first read about neural networks, because it really doesn't convey the complexity of these systems at all. And so I thought it might be interesting for you to see a video that I downloaded from YouTube, which shows a very primitive, simple neural network. This is a neural network with only 3 layers, and this is a neural network where we're only showing 2% of the synaptic connections. And so what you're feeding in on the other side of this is you take a picture of, in this case, digits. You put it in a 2-dimensional array of numbers. You feed it into the neural network, and at the end, it can make a classification decision. And so a lot of the early technology was on things like check recognition back in the 1980s and things like that. Now, that's a simple neural network. Just in the last month or two, Microsoft have described a neural network, a thing called a large language model, that has 538 billion parameters. That's 538 billion connections. So that gives you a sense of the kind of complexity of these systems. Now, my involvement in this space came really because back in 2016, I initiated the collaboration between Moorfields Eye Hospital and the artificial intelligence company DeepMind. And essentially, we were generating large numbers of these eye scans called OCT scans, and I wanted to work with them to develop a deep learning system that could triage those eye scans. So identify those patients with the most sight-threatening eye disease to get them in front of someone like me or my colleagues at Moorfields or others as soon as possible. So, not rocket science. These are the OCT scans. OCT is optical coherence tomography. And essentially, it's kind of like an ultrasound, but it measures the reflections of light waves instead of the echoes of sound waves. And in doing so, it gives us very high-resolution images. And it's become the dominant imaging modality by far in all of ophthalmology. In fact, the number of OCT scans that we do per year probably exceeds the number of CT scans or MRI scans that we do on a national basis. So it's running into the sort of 20, 30, 40 million, that sort of level. And we do about 1,000 OCT scans per day in Moorfields. So huge numbers of these scans. Now, in August 2018, we published the first results of this collaboration. We published in Nature Medicine, and as you can see, more than 30 different co-authors involved in the paper, just highlighting that this was a real multidisciplinary collaboration with ophthalmic expertise from Moorfields, scientific input from UCL, and computer science and engineering input from DeepMind. Now, it was featured on the cover of Nature Medicine, And of course, this being artificial intelligence, you can't escape the hype around it. And so it was thrilling to be able to get this sort of global media attention for this work. And I say that because, you know, I'm someone probably like a lot of people in the room who's published a lot of papers where you put your heart and soul into the paper and something you're really proud of, but actually probably only like 5 people end up reading the paper. And so it's nice then to be able to actually get the work out there and get broader attention. But also it's a little bit awkward, because the fact of the matter is we have not saved the sight of millions of people. And in fact, we have not even saved the sight of one person yet, despite the headlines here. And so the reason for that, I'll explain a little bit more in a moment, but essentially, it's one thing to publish a paper in a good journal. It's a very different thing to actually develop something that you can employ at scale on a global basis. And that's something we hope that we're making progress on. So this is the algorithm in action. Now, this is a little bit complicated, but what you can see on the bottom row here, this is an OCT scan of a patient in their 40s with poorly controlled diabetes. And we feed the OCT scan in, and we have 2 neural networks. And the first neural network is a segmentation network. And we've trained it to delineate all the disease features in the scan, and between 10 and 15 different disease features. In this case, you don't have to be an ophthalmologist to realize that this person has macular edema, waterlogging of the retina. Now that feeds into a second neural network, which does a classification output. You can see that on the top left. Now the writing might be hard to read, but essentially it gives a referral suggestion. So it says semi-urgent referral, and it gives a diagnosis probability, and it says macular retinal edema, 98.5%. Because our use case here is not to replace the ophthalmologist or the retinal specialist. Our use case is for non-experts to be able to triage those people and get them in front of experts as soon as possible. So where are we with this in 2021? Well, this is a guy called Ken Cukier, and Ken is one of the senior editors at The Economist, and he's someone that I got to know in the context of their interest in AI work. And some of you may have read one of his influential books called Big Data, one of the first books talking about this space. But essentially, in March of this year, Ken developed sudden loss of vision in his left eye, and he called me up on a Saturday and he said, like, what should I do? And I was able to direct him into the Moorfields Eye Casualty. He got seen, he got treated, he got sorted out. And a day or two later, he put this tweet out, which was kind of like gently teasing Moorfields and gently teasing me about the state of AI. So he said, AI is a fraud. I went to Moorfields for emergency eye surgery, and instead of DeepMind's cool algorithms diagnosing me and robot surgeons, I had to accept the excellent, skilled, thoughtful care of human medical staff. What a disappointment. Now, as it happens, the condition that he had was not something that would be diagnosed with an OCT scan, so our AI couldn't have helped him anyway, but nonetheless his point is a valid one, that there's still a lot of unrealized hype around these AI systems. And so really what we're trying to do now is bridge what we call the AI chasm. And this is a term that we took from the tech world. And it's the idea that if you're a startup doing machine learning, that it's one thing to like do a cool demo, raise some funding. It's a very different thing to have something where you can have meaningful human AI interactions at scale. And if you've got a chasm in the tech world, it's orders of magnitude bigger in the clinical world with all the regulatory barriers and other considerations that are important in this. So I'm not going to go too much into the details, but just to say one of the key aspects of that sort of process of going from code to clinic is the clinical validation of these systems. And one of the things that I hope to be able to talk to you about in the next year is a global validation study that we're doing. So we've sort of proved in our first paper that it works in a kind of, sort of pretty good in silico kind of retrospective study. But actually what we're doing now is we want to prove that an algorithm that's been trained on data from Moorfields also works as well in a patient with diabetes or macular degeneration or other retinal disease from Ghana, from Brazil, from Mexico, from the US, from many other countries and regions around the world. And so we've been working on that in the last year or two. So we want to go from code to clinic. At Moorfields, we're building a new hospital in the King's Cross area of London beginning next year. And so we're already thinking about how can we have the flexibility in the design of that hospital to take advantage of the new pathways of care that we believe that artificial intelligence will allow. But really what we're even more excited about is that the potential of AI, hype aside, is to bring world-class expertise out of specialized centers into the community and perhaps into the homes of people in the future. And we think that there's a real opportunity in ophthalmology in this regard because of the way that community optometry is set up and opticians and so on around the country, where we now have all the major optometry chains, Specsavers, for example, rolling out OCT as part of your standard eye examination. And not just Specsavers, but Vision Express, Costco, Boots, and many others. And so we think that that gives us the potential infrastructure to deploy the systems that we're developing. So that's the main thing I wanted to tell you about. Two other things I just wanted to talk about. The first is a thought experiment. So back in 2016, when I initiated the collaboration between Moorfields and DeepMind, what would have been required to do a cutting-edge clinical AI project? Because what I haven't told you is that before I approached DeepMind about this collaboration back in 2015, 2016, I went around academic collaborators looking for people that could help me with this, and really was met with shoulder shrugs to a large extent in terms of back in 2015, 2016. So what was required back then? Well, the first thing is you needed compute resources. And really that means something called GPUs, or graphical processing units. And you need lots of GPUs. And unfortunately, back then, even in a university high-performance computing setting, they weren't that commonly available, let alone in a hospital setting where the data actually resides. The other thing that you needed was very sophisticated technical expertise. And so over the last 5 or 6 years, you would often see this type of article where you would read these things about if you had a PhD from machine learning from Oxford or Stanford or MIT, and you were being snapped up by the leading tech companies and paid like the same salary that a sports star might get or something like that. So how could academia and how could hospital institutions compete in that sort of setting? So what I would say is, how has that changed in 2021? Or how will that change in the coming years? Well, firstly, in terms of compute resources, we've all, I think in our personal lives, begun to move to the cloud. So, the family photos that are on my phone are backed up to the cloud if I lose my phone, if I forget it here. We listen to music on Spotify, we watch our TV shows on Netflix or Amazon or the equivalent. And we're starting to see that also happen in healthcare settings. So in January 2018, NHS Digital gave national guidance supporting the use of the cloud for NHS data. And more recently then, we've seen a number of national services move to the cloud. So the NHS e-referral service uses Amazon Web Services, handles about 18 million appointments per year. And then even services like the NHS Blood and Transplant Service are on Microsoft Azure on the cloud. And then around the world, you have major hospitals, Mayo Clinic, Stanford, etc., all beginning to use the cloud. Now, the advantage of the cloud is that you have basically flexible, scalable, secure access to supercomputing facilities that you can turn on and off very, very easily. And so I think that that's going to be transformative in terms of using AI in healthcare. Now, perhaps more important is that the technical expertise has completely changed in the last few years. And so one of the things that I was most excited about was I read this article in the New York Times at the end of 2017 called Building AI That Can Build AI. And essentially, it's an article about how all the major tech companies have begun to develop these platforms that allow people with minimal or no coding expertise using drag and drop interfaces to train their own deep learning systems. So essentially, imagine you have, imagine you want to make a pet food app for your phone or something like that to recognize pet food or something like that. Or you want to develop an AI system to tell the difference between cats and dogs. If you have 1,000 photos of cats ready with labels and you have 1,000 photos of dogs ready, you can upload them to one of these systems, you can train a deep learning model, and then you can package and deploy that model in some way. So when we saw this, we got really, really excited. And so what we did was we downloaded 5 publicly available medical image data sets. So we got publicly available skin cancer lesions, or skin lesions, got publicly available chest x-rays, both from adults and from children. We got publicly available OCT scans, and we got publicly available retinal photographs from diabetic retinopathy screening. And so we went for public data sets, so we didn't have to worry about information governance or ethical approvals or other things like that. And the exciting thing was that within days, clinical researchers from our group were able to get results comparable to state of the art with minimal or no coding expertise. Now, I think that this is going to lead to a sea change in the ecosystem for AI-enabled healthcare in the coming years. So much of the work that we've done initially has been with industry. More recently, we have been able to establish academic collaborations, but really I think it's going to be clinical researchers driving this type of research in the coming years, because we're the ones with the ideas and we're the ones with trusted access to the data upon which to train these models. So we published the first results of that feasibility in the Lancet Digital Health at the end of 2019. And one of the things that I can't resist telling you as a slight tangent is that as part of the last revision process for that paper, the editor-in-chief of the Lancet Digital Health gave this comment to us. He said, "One point that we hope you will be able to address in the revision is to emphasize that these tools will not necessarily replace AI experts." Now, I couldn't help but smile when I read this, because of course, it was just nice to turn the tables on the AI experts for a change, because I've been talking about AI for a number of years, and of course the inevitable question is, will AI replace doctors? And of course, there's no way, I think in my lifetime, that AI is going to replace the complexities of what healthcare professionals do. And in the same way, these tools are not going to solve artificial general intelligence anytime soon either. So the first work that we did in Lancet Digital Health was using the Google AutoML Vision platform. And then we published work in March of this year in Nature Machine Intelligence, where we actually looked at the platforms from Amazon, from Microsoft, from Apple, and from a couple of others with these public medical imaging data sets. And they're all pretty good. And so if you're interested, you can sign up for the free tier of any of these platforms, and they typically give you a few $100s of free cloud credits. You can download some public data sets, and you can just start to play around, and you'll be amazed how quickly you can get good results. The other thing that we're trying to do is replicate high-profile clinical AI papers. So if there's papers in the New England Journal that have got a lot of hype around them by leading clinical AI groups, can we replicate them, but with limited technical expertise? So one of the first ones we targeted was this paper published in Nature Biomedical Engineering in 2018. This is from the Google Brain team in California. And this is a paper where they downloaded all the retinal photos from UK Biobank, and they tried to predict cardiovascular risk factors using deep learning. And they got sort of okay results, nothing that was going to really change things. But one of the interesting things about this paper was that they found that with deep learning, you could predict whether it's a man or a woman from a retinal photograph with a stunning degree of accuracy. And you may say, well, why? Who cares about that? I mean, there are easier ways to tell if it's a man or a woman than applying deep learning to a photograph. But of course, the reason why ophthalmologists got excited about that, and retina specialists like me, is because I've been looking at retinal photographs obsessively for 15 or more years, and I can't begin to tell whether it's a man or a woman from the photograph. So perhaps with deep learning, there's secrets that we can unlock from the data. Now that's a little bit of an aside, but what we did was we also downloaded the UK Biobank data, And in May of this year, we published work where we showed that we could actually replicate the findings of this world-leading engineering team from California using these code-free deep learning platforms. And watch this space for some of the other things that we're going to do, like diabetic retinopathy screening. Can we, with limited technical expertise, get better performance than an FDA-approved, commercially available diabetic retinopathy screening program? So I think this is exciting because I think it could be a bicycle for the mind. And this is a phrase that I borrowed from Steve Jobs. This is an advertisement for Apple, for the Apple II computer back in August 1980. And you won't be able to read this, but it's well worth looking up on the internet because it's fascinating to read the text of this. Because I think we forget now that back in the late 70s, the idea of a personal computer was crazy. And not just sort of crazy from the point of view of Joe Public, but actually crazy from the perspective of the mainstream computing industry. And so you had famous quotes like this from Ken Olsen, where he said, there's no reason why anyone would want a computer in their home. The computers that were available then were primitive, couldn't really do anything compared to the mainframe computers that were used by corporations to do payroll and so on and so forth. But Steve Jobs and Steve Wozniak and Bill Gates and others realized that if you gave these tools to people, even if primitive initially, they would come up with hundreds or thousands of applications that that the computing industry could never have imagined. And I think that that's what we will see in healthcare if we can start to make these tools more widely available. And even if you're skeptical about that, I think that there's a huge potential for this in medical education. And this is just to highlight an essay that I wrote with Professor Eric Topol in April of this year in The Lancet, that at the very least, having these tools is a way for clinicians to be able to probe the strengths and weaknesses of AI and learn more about those things. So my second last slide, just to finish up, let me just say, I just wanted to flag one thing that I haven't really talked about much yet in public, but that I'm super, super excited about. And that's something called privacy protecting machine learning. And so just really since the pandemic at Moorfields, we've initiated a collaboration with a UK startup called Bitfount. And Bitfount is essentially a company founded by this guy, Blaise Thompson. You'd be embarrassed to hear that I was telling you about him in this way, but essentially he's this really cool guy, did his PhD in Cambridge in information engineering, founded a company called Vocal IQ that does speech recognition that was acquired by Apple reputedly for some huge amount of money, and then he became the director or the head of the chief architect for Siri on the voice recognition system on Apple phones. And so he left Apple last year to form Bitfount, and essentially they're a company that do privacy protecting machine learning. So that includes things like federated learning. So the idea that you can train an AI system on data from Moorfields, from Liverpool, from Manchester, from multiple centers around the world without the data having to leave the institution. But also a range of other technologies such as differential privacy, homomorphic encryption, and a lot of other things. Now, the exciting thing from my perspective is that the system that they have is so easy that we've got it up and running at Moorfields and at UCL, and we can now train models on tabular data, on imaging data, and beginning to use genetic data in a privacy-protecting way. And I think that that's going to be transformative, not just the work from Bitfount, but it could be other startups involved in this space. Of course, I'm working closely with Bitfount, but essentially, I kind of envisage, like, I sort of see myself in 2030 as, I guess a senior consultant who sort of tells the medical students about this time, like back in 2008, I did a study in age-related macular degeneration, and it was the biggest study of its kind, and there was 300 patients, and it was like this amazing study. But I see in 2030, maybe we're doing a study in macular degeneration with every patient that's been diagnosed that year in the NHS or around the world. And it's these types of privacy-protecting technologies coupled with the increasing use of the cloud that I think will be the enabler for that. And maybe we'll look back on today and sort of think of like, maybe it's like looking back on silent movies or black and white TV or something like that in terms of the transformative effect. So just to finish then, I hope I've sort of given you a flavor that artificial intelligence has the potential to transform healthcare, and that ophthalmology is in many ways at the forefront of that. And then lastly, that's my email address. Thank you very much.